Now we are taking another topic here. This is called the intercostal apparatus. We can divide the entire region of thorax basically into four different subregions, four different compartments as far as the academics are concerned. One is a thoracic wall, number 2 is the lungs, number 3 the heart, and number 4 is the mediastinum. And after this, you see, if you are actually discussing here the first thing, that is called the intercostal, I say thoracic walls. The thoracic wall should be divided into the two parts. Half is the intercostal, this is the half is the thoracic cage, and half is the intercostal apparatus. This is basically a term that has been improvised. It's not written as such in the book, so you see that this improvised term is the intercostal apparatus, means everything related to this thing is the intercostals. As far as the thoracic cage was concerned, we have discussed before in the thoracic cage, where we have seen the bones, their landmarks, their joints, the ligaments, their clinicals, everything we have discussed in the first half of this first compartment, of the first portion of the thoracic say in the region of the thorax, that is called the thoracic wall, in which we discussed thoracic cage first. And in the second half of the thoracic wall, we are discussing here intercostal apparatus. Intercostal apparatus means you have to have some knowledge about the intercostal spaces, and these are gaps are filled by certain muscles. You see the three groups of the muscles we will actually be watching there. The external intercostal muscle, again intercostal, internal intercostal muscle, intercostal again, and then is the innermost intercostal also. The three groups of the muscles you will see that in the intercostal spaces. In between these muscles, in the intercostal spaces, you will see certain neurovascular bundles like intercostal nerves, again intercostal arteries, the anterior intercostal arteries, the posterior intercostal arteries, the intercostal veins, the anterior intercostal veins, the posterior intercostal veins, the nerves are just intercostal nerves, but anteriorly we can't actually have the nerves. These are these nerves which in fact will start from the spinal cord posteriorly, but it will come here anteriorly up to anterior midline, they will have to approach. So you see that it is called, all together you call it an intercostal apparatus, you see. So if you are actually looking at this, with this you see already I told you that it is called the intercostal spaces, intercostal muscles. This is external intercostal, internal intercostal and transverse thoracic muscle. Then intercostal nerves, intercostal arteries, we told you already, anterior intercostal arteries and the posterior intercostal arteries. Veins also, again anterior intercostal veins and posterior intercostal veins. So you see this all together you can call it now, informally you can call it the intercostal apparatus. Okay, with this now you are coming to the intercostal spaces. Already you know that this is a space between the ribs here. This is the first rib, this is the second rib, space should be called as the first intercostal space. Then this is the second rib, this is the third rib, second intercostal space. The third intercostal space, the 4, 5, 6, 7, 8 and 9th intercostal space. Likewise we have got the 10th and 11th, because we have 12 ribs, so we should have 11 intercostal spaces. There will be no 12th as such, you see that, but the space you say that the area below the 12th rib should be called as the subcostal area. This will be this area, because there is no 13th rib, that is why we call them, it is the 12th intercostal. You see that it is called the subcostal area. So you are watching here this, and we have already told you that the intercostal spaces can be counted by localizing first, you see, locating first this mandibulosternal joint by means of a transverse ridge that you can feel if you are actually passing your hand from jugular notch down. After 5 to 6 centimeters, you will see here there will be like a bump, you see that, and you will call this as mandibulosternal joint or the sternal angle. Lateral to that will be the second costal cartilage, and here more laterally will be the second rib. Above this will be the first intercostal space, below that will be the second, and after that there will be the third rib, and likewise you will see the intercostal spaces, the corresponding intercostal spaces lying below there below their corresponding ribs, you can say. So, these are called the intercostal spaces, and when we are discussing intercostal spaces here, you see this, these are the spaces, and in these spaces, and this will be the subcostal area. And if you are actually passing here, if you look at the inferior thoracic aperture, you see already I told you that this is the fired process. This is costal cartilage. This is first, second, third, 4, 5, 6, 7. This is costal cartilage 7. Then this is the costal cartilage 8th. This is 9th. This is the 10th. See, you are going here. Then this is the tip of the 11th rib, the lower border of 11th. Then is the tip of the 12th and lower border of 12th. You are reaching here to the area that is called the lower border of the T12 vertebra. That means this will be all. This is called the costal margin. Any structure which is lying under the diaphragm, being abdominal structure, it will gets enlarged here. You see, it will be now palpable below the costal margin. Like the spleen will be palpable below the costal margin, but at least when it will get its enlargement will be more than, you see, when it is twice its mass, if it is increased by almost, you say, twice it is increased in size, then it will be palpable below the left costal margin. But this is not true with the liver. Liver is gets little enlarged, it will be felt here under the right costal margin. Okay, so this will be here when you are actually discussing here these intercostal apparatus, intercostal arteries, veins, nerves, as well as the muscles. You should have good knowledge about the ribs also, which you have seen in the thoracic cage. It has the head, it has the neck, the tubercle you have seen here behind. The costal transverse joint is formed there. It has the upper margin which is blunt here, and the sharp lower margin. These things you must have in your mind when you are actually discussing here the intercostal apparatus. So, the rib anatomy is important in this sense. As far as this in the costal cartilages also, you should have knowledge about this. So, inferior border of the ribs, sharp inferior border, and deeper to the inferior border, you see from the thoracic side, not from outside but thoracic side, there will be a groove also. This is called the subcostal groove. This should have actually been kept in mind here also. So, you should have these things in your knowledge also, and then you will enter into the intercostal apparatus, means intercostal muscles and intercostal neurovascular bundles. As far as the intercostal muscles are concerned, you will see that first group of muscles that is called the external intercostal muscle. Watch them, because we have three intercostal muscles. And if you are looking at this, you watch here, this is a cut section. The cut section, you are watching this blunt superior border, and you are watching here this sharp inferior border. If you see, this is here again. If you are watching this blunt inferior, you see here again. You see blunt superior border, the sharp inferior border. This is a cut section of here, and here you see this blunt superior border, the sharp inferior border, and immediately you will see here there is a groove also inside the deeper. You see the rib is like this. Is the cut section of the rib. This is a cancellous bone. So, this is here a groove. You are watching this groove again. You see this here. Watch here this. This is a blunt superior border, and sharp inferior border, And here we have the three muscles here. If you are actually looking at this, you see here again, we have three muscles here. The first muscle is, if you see here, this is skin, this is superficial fascia. And this is externally, you see that this is a membranous layer of superficial fascia. This was the fatty layer. Usually deep fascia doesn't exist. If it exists at all, it will be rudimentary, because the deep fascia which is actually present here, it should be rudimentary. So, deep fascia which will be present, understand. So, deep fascia should not be present here in the thorax, because if the deep fascia is like the deep fascia regularly present in your limbs and other portions of your body, if it is present actually, if it were present here in the thorax would not have expanded here to accommodate the extra air when you are actually requiring or when you need that. because the deep fascia usually is unyielding fascia and does not in fact allow the expansion. So, we have here skin superficial fascia, fatty layer and is a membranous. Here superficial fascia has 2 layers just like in abdomen, and then are the 3 muscles here 1, 2 and 3. There are 3 groups of muscles, and these muscles groups, but their fibers in fact they are the direction of the fibers is different. You see that one direction of the superficial muscle fibers, they are obliquely downward and forward like this, and when you will actually be looking at the other group, that is the internal intercostal muscle, their fibers will be upward and say backward here like this. This is second group. So, this will be under them. I am giving you this broken lines here in such a way that the first group and second group fibers will actually make 90 degree with each other. And if you look at your third muscle, you see that is lying deeper, that is the transverse abdominis, that will be transverse. I am giving it much is a in dotted line here. This is the third muscle, this will be inside. Means the first muscle it will be downward obliquely and forward, you see like this. If you see from from this side also, so downward obliquely and forward like this. Other will be upward obliquely and backward, deeper to that, and the third will be transverse, deepest to all of them. Your 3 muscle group are like here. So, outer group, I say outer layer is the external intercostal, middle is the internal intercostal, and the last will be transverse thoracic muscle. And when you look at these muscles here, you see that, look at these muscles, your neurovascular bundles in fact will be trapped between the 2 layers. If you have got 3 transverse abdominis, I say transverse thoracic, internal intercostal, external intercostal, these are 3 muscles groups are there. Your neurovascular bundles is lying between the deepest and the middle layer here. Vein first, artery next, nerve last, in a VAN arrangement. So, if you look at this here again, you see this vein, artery, nerve. This is VAN arrangement. And this is what we call here the arteries, veins and nerves, and this is the neurovascular bundles, intercostal neurovascular bundles, as a part of the intercostal apparatus. And if you are actually looking at this, I told you that again this muscle, external intercostal, in the reverse direction you see in the contrast it will be internal intercostal and transverse abdominis. They have been cut actually to show you all these 3, but they are overlapping each other. So, these are the muscles which are you actually watching here. So, usually is the muscle site here, you can see in this diagram also skin, superficial fascia, fatty layer, then you have got membranous layer, and then you are seeing here the muscles, and the muscle there is external intercostal, this is internal intercostal, and inside will be the transverse abdominis also, transverse thoracic also, I am sorry. And then inside will be now little bit of fat, then inside you are actually watching here a fascia, that is called the endothoracic fascia, and the last will be the thin serous membrane, that is called the pleura, parietal pleura. You can see this cut, the parietal pleura has been cut here. This is called the parietal pleura. All these things here right from skin. So, 2 layers, you see 2 layers outside skin, 3 skin, superficial fascia, fatty layer and a membranous layer. Then will be the 3 muscles, surely will be intervening will be the ribs also, external intercostal, internal intercostal, transverse abdominis. Then 3 layer outside we have seen and 3 layer inside you will see. 3 layer inside means the last here after these 3 muscles there will be here, this is called endothoracic fascia, then little fat, then will be this serous membrane, that is called the pleura, parietal pleura. So, this fat should be called the extrapleural fat. So, you can see here very easily 3 layer superficial, 3 layer deep and 3 layers are the muscles here. Means if you are passing the needle here and will reach this fluid which is lying deeper to the parietal pleura in this space, that is called the pleural space, you have to cross 9 layers, and in sequence you have to actually name them, because this is usually asked in the examinations. And if you see this this thing here, you see, but I told you that if you are actually discussing your inferior border, superior border and all these things, that means we are when you are discussing the various parts of the muscles here, you should have a good idea about the ribs here, the inferior border, superior border, etc. like here. And with this you are coming here to the external intercostal muscle. I told you that the external intercostal muscles, if you are looking at them, these fibers are directly, you see, these fibers are directed obliquely downward and forward like this, downward and forward like this, downward and forward. From where? From above to down, from above, from the rib above to the rib below. Rib above means it will take origin from where? It will take origin from the sharp inferior border of the rib above and be inserted here to the blunt superior border. But which part of blunt superior border? If you see here, the outer part of outer part of the blunt superior border of the immediate the next rib here. So you can say here from the inferior border of your rib to the sharp superior border of the next rib, sharp outer surface of the blunt superior border. So if you are actually looking at your you see like this, rib number 1 cut section, and if you are looking at your rib number 2 cut section, so it is from the inferior sharp border of this inferior sharp border of you see this muscle, this to the outer part of the blunt superior border of the next rib here. How you see skin, superficial fascia, fatty layer and the membranous layer. So this is the muscle which are called as, but these fibers I am actually showing you cut section, but these fibers when they are running like this, obliquely downward and forward from the sharp lower border of the rib above to the outer lip of you can say outer part of your outer lip of the blunt upper borders, outer lip of the blunt upper border of the rib below. So you can see this also, and fibers direction you are already watching. But external intercostal muscle, what will be its extent basically? If you see this extent here, what will be its extent? Means from the entirety, you start from behind up to your sternum in front. You see from here means from the midline here, means you can say from the midline here. So you can see if the midline behind here that passes at the middle of your vertebral column, and here is passing at the middle of your sternum here. In total, if you are actually watching your external intercostal muscle is this. This is your external intercostal muscle. It starts from posteriorly, it starts between the ribs obviously, direction you have already seen, but this is found where? This is found between the two ribs obviously, but if you start from behind, it will be starting actually at the tip of the transverse process of the vertebra. From here it starts, its existence will be from here. Tip of the transverse process, already you know that there is a facet, costal facet, and there is a joint also. Joint at the tubercle of the rib with the tubercle of the rib with the transverse process tip at the costal facet here. The name is the costotransverse joint. Means this muscle actually starts posteriorly from the level of between the ribs obviously, but from the level of costotransverse joint or at the tubercle of the rib. Anteriorly it is continuously coming here and here and here up to the costochondral junction. Not up to the side of your sternum, but up to the costochondral junction, where it will be replaced by this thin you see here again is a thin membrane here. You see this, here is a thin membrane. You see from other side also this thin membrane, and that thin membrane is called external intercostal membrane, or this is called anterior intercostal membrane also, this one here. Anterior intercostal membrane. So anteriorly you see anterior intercostal membrane. So that means if you are passing your needle very close to the lateral margin of your sternum anteriorly, your needle will pass through the obviously skin, superficial fascia, fatty layer, membranous layer, not the muscle but the membrane. That is called the, and that will be the membrane, that is called the anterior intercostal membrane here. This is important, this is usually asked in the exams. So it's extend from behind till anteriorly, it is important here. You see this muscle has been actually shown you here in this diagram also. You see here this green color which you are actually seeing here. So, see this is a muscle, so obliquely forward. So, starting from where? Starting from here, and anteriorly it is actually coming here. See that it is starting here, it's obliquely downward and forward fibers here till they will reach up to the front, but here not up to here, this level, external intercostal. So, you are watching this external intercostal muscle also here. See this external intercostal. Again you are watching external intercostal muscle, and they are rib to rib. You see that from one rib to other rib. The first external intercostal, then second, third, fourth, and there is a fifth intercostal space here, sixth, seventh. You see the direction of the fibers. You are watching here. See again. These are the external intercostal muscles. Their function will be what? We see that if their function, if you look at these functions, because these are the intercostal muscles, so especially when they contract, fixing the upper rib, they will lift the lower rib actually, and the rib will be actually lifted up here, and rib will be lifted in such a way that its costotransverse joint, the tubercle will rotate inside the costal facet at the tip of the transverse process of its corresponding vertebra at the costotransverse joint. So, rib will be lifted, especially upper 6 ribs will be lifted, and will lifted up here, sternum will be lifted also. The anterior posterior diameter of the thorax will be increased, pressure will become less, and inspiration will become easier. So, it will be actually a muscle of inspiration, but usually it is used in forced inspiration, because in inspiration usually the vertical diameter is increased by depressing the diaphragm down here to increase the volume space inside the thoracic cavity. Depressing the diaphragm down, depressing the diaphragm towards the abdomen here, it will increase the vertical diameter of your thorax and decreases the pressure, and pressure inside will be decreased and outside will remain constant here, atmospheric pressure. So, air can enter into the nose very easily because there is a difference of pressures. Not only this, but these ribs when they contract, you see the lower, especially the lower ribs will go laterally. So, even the lateral diameter will be increased also because of the contraction of the external intercostal muscles of the lower ribs, and upper ribs it will lift the sternum as well as the ribs here. Means this muscle, when this muscle will contract, it will actually cause the this will lift the next rib to which it is actually inserted here. But the lower ribs in fact will, when they contract the external intercostal muscle, the lower ribs will go laterally. So, lateral diameter will increase. So, lateral diameter increases due to the contraction of external intercostal muscle, inferior in between the inferior intercostal spaces, and the elevation of the ribs when this will be upper ribs will be elevated here, and with this anterior posterior diameter will be much expanded here, but the vertical diameter has already expanded when your diaphragm is contracting, because with the contraction of diaphragm goes down, depresses into the abdomen. You see, it goes into the abdomen. So, it is a muscle of inspiration basically, but at the same time you know that it supports intercostal spaces also, and because intercostal nerves are passing between the spaces, so surely it will be supplied here by the intercostal nerves. The intercostal nerves will supply these external intercostal muscle. After that, the second group you know that is called the internal intercostal muscles. Again you watch here. This time you see the muscles here. The first muscle, which was external intercostal, you see here coming downward obliquely and forward. But the other fibers, you see, if other fibers I am telling you, the internal intercostal fibers, they in fact take origin from the rib below and inserted in the rib above. You said that if the rib below, for example, so that means it will take origin from the blunt border, which lip? The inner lip, this time you call it inner lip. If you see here, if you are causing this one here, so this border, it was external intercostal, and if internal intercostal means it will take origin from the inner lip of, you see, inner lip of the rib below to be inserted here to not the sharp inferior border as such, I will say, because sharp inferior border was not too broad here, because already occupied by the external intercostal. So, this will in fact be inserted little inside this border, and little inside this border, you know that you say, sir, we have already costal groove here. Okay, you can say inferior lip of the costal groove. This is inferior lip of the costal groove. This will be inferior lip of the costal groove, and this is the superior lip of the costal groove. So, this will be inserted to inferior lip of the costal groove, means taking origin from, you see here again, if taking origin, you see taking origin from the inner lip of or the inner aspect, inner part of you, the blunt upper border of the rib below, reverse now, and inserted into the inferior lip of the costal groove above. You see, this was reverse, inferior border of the rib above and the outer part of your blunt inferior border of the rib below. This time inner lip of the superior blunt border of the rib below and inserted above, not to the sharp inferior border because inferior border has been already occupied, inner lip of the costal groove. This is the costal groove. So inner lip of the costal groove, and this is the superior lip of the upper lip of the costal groove. This is the inferior lip of the costal groove, because the superior lip of the costal groove will be in fact give attachment to the third muscle here, this one. That's why neurovascular bundle will be trapped between the second and the third layer muscles here, second layer and third layer, second and third. Third we are coming in a short time, but this will be actually called the internal intercostal muscle. But the fibers which are actually going here are taking origin from the lower rib and inserted to the upper rib, but surely the fibers are in fact in such a way that the fibers are going like this. You see, they are surely overlapped by external oblique, but external intercostal, but I am showing you here, like you see this, going upward, backward, obliquely upward and backward here. And we have told you that those fibers which were actually your external intercostal fibers, they were coming like this. So the fibers of your internal oblique, I say internal intercostal, and fibers of your external intercostal, they are in this direction, means they are making 90-degree angle with each other. So they are actually like this. So what they will be actually doing here, so if you are looking at them, you see this is internal intercostal, they are going obliquely upward and backward like here. The external intercostals, they were coming like this. And this, if they are here, so what they are doing, they are actually fixing this rib and they are depressing this rib. Depressing means the reverse section. A reverse section means if they are depressing, so reverse section means they are actually depressing the ribs. Anterior posterior diameter will be decreased. Volume inside the thoracic cavity will be decreased, pressure more as compared to the outside here, so air can actually be expelled outside for forced expiration. So for this purpose, you see this muscle is important from this point of view. You see, again I told you that the external intercostal and inside will be the internal intercostal also. So you can say these are the internal intercostal. External intercostal has been removed and I am showing you this is internal intercostal. Upward and backward, you see, obliquely upward and backward. This was obliquely downward and forward. One superficial and second deeper. But as far as the extent is concerned, again important from this point of view. You see extent, how much is actually from behind the till front, how much is present here. You see reverse, it is almost, you see, reverse. Anteriorly it starts from, you see, anteriorly it immediately starts here very close to the say sternocostal junction here, where the costal cartilage is attached to the side of the to the side of the sternum here. So it starts as a muscle here, okay, it's coming here as a muscle, muscular say belly is there, here till when it reaches to the angle of the rib here behind, posteriorly the angle of the rib, it is replaced by a membrane. You see this green color I am showing you here, membrane up to the tubercle of the rib here. So reverse here. Previously in the external intercostal the membrane was anterior, and here this time the membrane is posterior. This membrane is called the internal intercostal membrane, or you can call it now posterior intercostal membrane. It's called the posterior intercostal membrane. You can call it internal intercostal membrane also, because it's a part of the internal intercostal muscle. This is the extent you see posteriorly and anteriorly this muscle, but direction of the fibers between the ribs already you have seen, and to the extent already you are actually watching here. Internal intercostal, watch this second layer muscle. This is the outer one and this is the inner one. You are watching here these fibers you see here like this, and watching the other fibers like this. But you see this green color is the internal intercostal. Again I told you that depressing them, and it's obviously depressing the ribs during forced expiration, because for normal expiration, just the diaphragm going up due to elasticity, because elastic recoil of the diaphragm goes up here at the time of relaxation. With the contraction phase is over, diaphragm comes back again due to elasticity when the nerve supply is switched off, and this will cause the vertical diameter of the diaphragm will be decreased also. The pressure will increase, air will go out. And nerve supply, surely like same, the nerve supply, the corresponding nerve which is running in the intercostal space. These are the intercostal nerves. Okay, when you bring up here, the third muscle is called the transversus thoracis muscle. Transverse muscle of the abdomen. I say transverse muscle of the thorax here. We have got the transversus abdominis muscle also. Like we have the external intercostal, similar analog, you see homologous to this in the abdomen is in the same configuration. In the abdomen we have got external oblique muscle. We have got the internal intercostal muscle with the same configuration we have in the abdomen, internal oblique muscle. Second muscle, second group of, as a second big muscle here, sheet like. Where here the third muscle which you see that is called the transversus thoracis muscle here. In the abdomen we have transversus abdominis muscle, and similarly 3 layers like the skin, superficial fascia, fatty layer and membranous layer, no deep fascia. After the deep fascia is there, rudimentary again, same abdomen like thorax. And inside the muscles we have 3 layers also. We told you that it is called what? Endothoracic fascia. Here in you see here it will be the endothoracic fascia. You see the last one here will be the endothoracic fascia here, and there will be fascia transversalis in case of abdomen. Then was the fat here, extrapleural fat, there will be extraperitoneal fat. Why? Because here is the extrapleural fat. Why here extrapleural fat? Because the 9th layer which you are seeing, the innermost means out of these 3, the third and last layer is the pleura, parietal pleura. Here parietal peritoneum was there. That's why the fat here is called the extrapleural fat, there will be called as extraperitoneal fat. Same 3 layers means same here. If you reach here, then the fluid will come. There peritoneal fluid in case of abdomen, here will be the pleural fluid here. There will be the viscera, here will be the lung. So if you are putting the needle here, you have to pass through the 9 layers till you reach the fluid. Same in the abdominal fluid, if you are bringing out the fluid or tapping the fluid in the abdominal cavity or peritoneal cavity, same 9 layers. Because abdominal wall and thoracic wall anteriorly, it is not different. They are almost identical, you see. Only difference is intervening in the chest will be the ribs, and nothing is intervening here in the abdominal wall. It is like sheets, you can say. That's why we call them oblique muscles. We don't call them intercostal muscles. So here again you are watching the same. I told you that the transversus abdominis muscle, especially you see the transversus abdominis muscle, transversus thoracis muscle here. This is divided into 3 parts. It is not like intercostal. Basically, it is lying from the inner aspect of your chest wall. It is actually here. So it is like this. It is having 3 parts. You can say. See this first part. After that, you have just membrane. Then will come your second part. After that, you will have membrane also, and then will be having a third part here. So you can say we have got basically 3 parts of the same muscle here. First part is this, just lying behind the sternum, and then you are watching the second part, which is present here deeper to the ribs here, and there is third part which is lying in these depressions here. So the depression means if you are actually cutting your trunk here, you have the vertebra, and you have got the ribs here, and these are the depressions. You see that they are the concavities on 2 sides of the vertebra. We call them paravertebral gutters. So in the paravertebral gutters here, we have got a third part of this same muscle here, because they are in fact in patches. You see the first part, then the second part, third part, connected by membranes obviously, and they are not rib to rib here. They basically, you see that if these are the ribs here, you see these are ribs. If you are seeing from inside here, if you have got the sternum, if you are seeing from inside, so these are not between ribs to ribs. They are actually covering 4 to 5 or 2 to 3 spaces together. They will be covering. This will be. If I am telling you this muscle, this is called this muscle, sternocostalis muscle you call it. This second one is called the intercostalis intima, innermost intercostal. And this last muscle, this is called the subcostalis. This last portion is called the subcostalis. These are 3 segments of the same muscle that is called the thoracis. we call them transverse thoracic muscle. And these muscles are not between rib to rib, they are actually covering like patches, and they are covering 2 to 3 spaces together without interruption. So they cannot be called as actually intercostals, but they are lying inside obviously. So first muscle group that I was telling you, this small slip, small muscle covering 2 to 3 ribs, obviously 2 to 3 spaces here. From the posterior surface of the lower part of the sternum it will take origin, and then they will diverge here. So 2 to 3 or 2 to say from second to 6th costal cartilage slips will be there, crossing more than one intercostal space, 1 to 2 to 3 like here. So you can see this also. And after that there is a membrane coming, and then again the same muscle second segment will come, and that is much larger. You can see these muscles. Sternocostal is part of the transverse thoracic, you can see. It can even be here like this here, 2 spaces covered together. This is from the innermost here, because in between already you have seen external intercostal and the internal intercostal. This is sternocostal, but the second one I told you that this one here, this is called the intercostalis intima, it's called the innermost intercostal. Inner surfaces of the ribs on the lateral part of the thoracic wall, crosses again more than 1 spaces. You see this muscle. And then we have seen this intercostals here, the transverse thoracic. So you see this in the lateral side, it is actually occupying here. 2 to 3 ribs they can even cover. And the last one that is lying here in the paravertebral gutters, attached here to the inner aspects of the rib, obviously in this region, after the angle, up to the tubercles, again crosses more than 1 spaces obviously. So this you see in form of, if you are actually looking from inside here, from the thoracic cavity, it will be like in patches, you can say. You see transverse thoracic muscle, we will go inside here, these small pieces we are watching here, because it is in form of pieces here. And similarly we have got this transverse abdominis in the abdomen also. And this is, we have got, so these muscles also will support the intercostal spaces also. So you will be actually looking at these muscles, they are important, and questions are asked in them. After these intercostal muscles, you are actually going into the intercostal neurovascular bundles, and first we take up this called the intercostal nerves. Now look at them and understand them. You see these are the nerves which have been shown you here. Here the arteries and veins, we will discuss them later, but you see the nerves here. Nerves will emerge, you see that from the intervertebral foramen. We have got 8 cervical nerves, we have 12 thoracic nerves, we have 5 lumbars, we have 5 sacrals and 1 coccygeal. We have got 31 spinal nerves. Now look at them. Now if for example you are looking at the intercostal nerves, you see, if I am telling you here is the thoracic 1 vertebra, here is the thoracic 2, here is the thoracic 3, and we already know that there is lying intervertebral foramen between the vertebrae, and here we have the spinal cord which is lying inside it. And nerves are actually emerging in form of sensory and motor root from the spinal cord, and sensory and motor roots join here in the intervertebral foramen, and mixed nerve comes out. You see the mixed nerve come out. If it is a T1 vertebra, below the inferior part of the T1 vertebra must be T1 nerve, means all the nerves, at least the thoracic nerves, not all of them, but the thoracic nerves, they emerge from the lower parts of their corresponding vertebrae. If it is T1, so it should be between T1 and T2, or you can say simply below the T1 lower border, or in the intervertebral foramen between T1 and T2 will emerge your first thoracic nerve, and then likewise it will be second now and third also. Immediately this is the, and this nerve is the mixed nerve obviously, because their sensory and motor fibers, they join before they leave now, before they come out of the intervertebral foramen. So in the intervertebral foramen actually their fusion, their union and their merging will take place as far as the sensory motor roots fibers are concerned. So when it comes out here, so it will be sensory and as a motor together. We call them mixed nerve. But when the mixed nerve comes out, you see that if you are cutting your section of the body here like this, your trunk, and here it was your spinal cord, I say your vertebral column here, spine was here, transverse processes, and your sensory motor roots, they are here, and they are coming here. Motor, for example, this is a mixed nerve. If I am telling you is a mixed nerve, this one. Then the mixed nerve has now two problems here. If you cut your body into two halves, very small part in the posterior midline, very small part, hardly 4 finger breadth on you say on either side, 4 finger breadth, you see it, 4 fingers wide only. This part of your back side of your skin and the underlying muscles, this is you call the dorsal part of your body. But this one you see that is all your lateral as well as your anterior, all together this is called the ventral part of your body. And you know that from this lateral part actually your limbs emerge. Means limbs belong to the ventral part of your body. Limbs are never from the dorsal. Obviously you see the limbs but do not appear here or they emerge from your posterior side. They are from lateral side. The lateral side is actually the territory of the ventral region. So this means if your nerve is coming here, nerve has actually love for both regions here, the dorsal as well as ventral. Understand, dorsal and the ventral here. And if the dorsal, for example, if you are looking at the dorsal, so that means the nerve should actually supply the dorsal region, sensory motor both, and the ventral region, sensory motor both. Understand? If the dorsal and ventral, so this nerve when it emerges, it should actually split immediately into the two rami, you can say. The posterior, I said dorsal ramus, smaller one obviously, because the dorsal region is lying in that area. But the ventral region is because it is very big here, so the ventral ramus will be very, very long here. It is running in the anterior aspect, lateral aspect, up to reaching up to the anterior midline here. The very long ramus is there. This is the anterior ramus of any nerve. So if I am actually taking this one here, you see this a very small posterior ramus that will split up here actually in the medial lateral branches, no problem. But the long, very long and large will be your anterior ramus, because the anterior ramus has got a lot of responsibilities, because it will reach up to here. Because you know that already your intercostal muscles started here from the tip of the transverse processes here, like here. So your posterior rami will have nothing to do with the intercostal spaces. As such, you see that they will not actually pass forward in between these three muscles here, especially the third and second muscle. You know that the nerve should actually be passing, or the arteries and the veins, they should be passing between the transverse thoraces inside and the internal intercostal muscle outside here. In that space it will running here in the groove, in the costal groove, you see there. So this will be actually, so the posterior ramus is actually having nothing to do with intercostal spaces. So posterior ramus, though nerve is thoracic, but this posterior ramus will never be called as the intercostal nerve. But the anterior ramus, because it courses forward, courses forward and will pass between the muscles. Which muscle? The three which you have seen, intercostal muscles, and obviously they will be sandwiched, they will be covered by superficially with the internal intercostal, because they are running between the second and third layer, not between first and second and third. So they are actually having outside internal intercostal, inside will be transverse thoracic muscle. So they are running, why? Because they are running in the costal groove, and because they are running in the costal groove until they will reach here to the anterior side here up to the sternum. That's why these anterior rami of the thoracic nerves are called the intercostal nerves. But you see that thoracic nerves are 12 and intercostal spaces are 11. So we have actually 11 intercostal, but okay, no problem, because the last nerve is passing below the rib, because below the rib is not called the intercostal region, we call them subcostal, okay, no problem. Anterior ramus of your last thoracic nerve should be called as subcostal nerve. There is no problem for the 12, but we have got all these nerves which are actually present here from 1 to 11, they are called intercostal nerves, because they are running in the groove. And they are running in the groove between the second and the third layer of the muscles here. So anterior rami of your thoracic nerves are called the intercostal nerves. Not the entire thoracic nerve is called intercostal, because already it has given posterior ramus, and then whatever will be the next part of your thoracic nerve will be called as the anterior ramus, and its name will be, nickname is intercostal nerve because of its location. So intercostal nerves are basically the anterior rami of the thoracic nerves, though last thoracic nerve, the anterior ramus, is called the subcostal. So intercostal nerves you are actually watching, you see this green color. Above will be, here will be the vein, and then is the artery, then is the nerve. This is VAN arrangement between the two muscles, I say. Between two means inside will be, you are watching here inside, here on the back side you will see this is the muscles. These are called the internal, I say, intercostal. Intercostal is intima, the innermost intercostal on the back side you are watching. And this is now entering, you see the muscles are entering, this nerve is entering, disappear. Why? Because this is the muscle, this is the innermost intercostal, transverse thoracic portion. You see, it is covering here, not one space, it is covering, you see 2 to 3 spaces here. Here it is covering 1, but it can cover 2 here also, you see that. Here it is covering 1 only, but it can cover even 2 to 3. Here it can cover even 2 to 3 like that. So intercostal nerves are like this here. You can see this intercostal nerves, and I have told you already, this intercostal nerves, they have already given posterior ramus. Leave the posterior ramus, this is none of your business, this is actually related to the posterior side. This will be actually, this will here, this is called intercostal nerve. Because it is entering between what? It is entering between the second and third layer, and second layer you know that is called intercostal, and behind second layer is not intercostal. At that time it was posterior intercostal membrane, it was present. So it is enters between subcostalis and the posterior, you see, between subcostalis, part of the transverse thoracis, and posterior intercostal membrane, then it is entering between them here. Then is no problem, it is coming here between innermost intercostal, I say this is innermost intercostal, this one, and the internal intercostal. Then it is coming like this here. This is artery, but the nerves are running here also. This intercostal nerve which you are actually seeing here. See this again, intercostal nerves which are actually running like this. And its total course, posterior ramus, leave it. Posterior ramus is not called internal intercostal, though it is a part of, she is the daughter of also, you see that of the thoracic nerve. But this big, you see that is this nerve. This very long daughter, you see that, which covers the anterior lateral portion, which is covering the anterior portion of your entire body, your trunk, your thorax also. It is called intercostal nerves. And intercostal nerves, because actually the nerves are running, you see the nerves, if you see the nerves also right from cervical here and the thoracic here, nerves are not running all this, you see that in parallelism here like this. Upper nerves, you see that when they emerge, they are horizontal. If you come down here, the space between the two nerves, adjacent nerves, will be little larger here. See this here. So that's upper nerves, you see cervical nerves, they progressively actually gets more horizontal, then become more oblique, more till the last nerves, lumbar and sacral, are almost vertical. That indicates with the intercostal nerves they are 12. So upper intercostal nerves usually they are in the range of the thorax, starting from back side till the front they are in the range of the thorax, but you see sternum finishes very quickly. So the last 6 nerves, in fact, their terminal course will be in the abdomen. So much so that the 10th nerve passes, you know that, at the level of umbilicus, 11th below that, and 12th will be just above the apex symphysis, and 9th will be above the umbilicus, 8th will be still above, and you see that even the 7th will be in the region of even the epigastrium, just below the region, you see just the skin above your stomach, or you say just the skin where you are feeling here the tip of the xiphoid process, just below that where you can feel your stomach. This is the territory of the 7th intercostal nerve. You see that in the abdomen intercostal, yes, lower 6 intercostal nerves, in fact their terminal portions will come into the abdomen, and it has a important clinical implication. And when the nerves are in fact going like this here, you see that these nerves during their course, if you see these nerves, you see these nerves during their course, if you are looking at these nerves, okay, we will watch them here. If during their course these nerves, when they are running, when they reach laterally, feel your body also, they reach laterally at a point, especially between the ribs, obviously in the costal groove, at a point that is called the mid-axillary point. Mid-axillary point means at a line that you can draw between the two axillary folds. When they reach at the lateral side at the mid-axillary point here, say mid-axillary line, at mid-axillary line region, mid-axillary line point here, the point which lies on the mid-axillary line, when it reaches, it gives here a branch, and that is called its lateral cutaneous branch. If say lateral cutaneous branch means it will cover now, it will penetrate all the muscles which are there, all the two muscles obviously, because the one is the deepest. It will be internal intercostal, external intercostal, then the skin, I say membranous layer, superficial fascia, fatty layer, superficial fascia, and under the skin it will come here and it will spread here. Posterior branch, anterior branch. This is called the lateral cutaneous branch of this intercostal nerve, supplying your skin. Which is skin? You see posterior branch also, posterior branch will supply until there will be the say lateral branch of the posterior ramus, it finishes here. It will be taken over by this. And medial branch of your posterior ramus, it will reach up to the midline posteriorly. So you see whole dermatome, whole space, whole span of skin will be supplied here. So this lateral cutaneous branch, its anterior branch will come where? Anterior branch will continue up to midline? No, not up to midline. It will continue few inches here, then it will stop here. This is the lateral cutaneous branch of your nerve, of your lateral cutaneous branch of your intercostal nerve is this. Full skin not yet supplied, because from anterior midline there are a lot of inches still remaining here up to your nipple and other things here, but no problem, the nerve continues in the costal groove till it reaches here to the side of the sternum, and then it comes out as anterior cutaneous branch, and then anterior cutaneous branch will give you here a lateral branch that will be using, or you say supplying the skin up to where the anterior branch of lateral cutaneous nerve of the intercostal nerve finishes here. So this will supply, and here its medial branch will be going up to the midline here. Now you can see right from behind up to your midline anteriorly, entire skin, belt of the skin, dermatome of the skin, or that piece of skin has been supplied by this corresponding nerve. These are called dermatomes, and these are the oblique bands of skin, in fact here. Why oblique bands? Because the nerves themselves are oblique, and these nerves are there, and so much so that such bands or such dermatomes of your skin, they are actually coming and they are supplying your understand. So they will be supplying even the piece of the skin also. These are called the dermatomes. I told you the 10th dermatome passes over the 10th belt of the skin. In fact, T10 band of the skin actually will be passing over the umbilicus. Likewise, these dermatomes are important. So when the intercostal nerves will be having a problem and you are injuring them or having any problem in them, you will see you will have a problem even in the abdominal wall. So pattern of distribution you have already seen, and the different nerve, the pattern is little different. You see that not all the nerves are typical nerves. If you look at your first intercostal nerve, you know that it enters into, okay, because there is no costal groove as such here in the first rib, because first rib is actually different from the others. So it will surely it will give its posterior ramus, then it will, because it is very small, the intercostal space number 1 is very small space, it is not very long, you say short space here. So anterior ramus T1, it gives actually it is coming here, T1 say anterior ramus will become now intercostal, first intercostal. This runs under the flat inferior surface of your first rib, because no costal groove, and here it will going actually it will just disappear inside it. It will not give in even its lateral branch, it will not give even its anterior branch, cutaneous. Why? Because at the sternal angle, above the level of the sternal angle, whatever skin will come, that will be supplied by the cervical plexus, cervical nerves, not by the thoracic. That's why no lateral cutaneous branch, no anterior cutaneous branch is actually required in T1. In first intercostal, it is not required in the first intercostal. It doesn't have actually its dermatome on the thorax. It doesn't have its dermatome at all. You say, why this nerve is present? Obviously, this nerve has to supply the muscles, obviously, and the nerve will supply the deeper structures like the periosteum of the ribs, and also inside the endothoracic fascia and parietal peritoneum. They can supply, but no skin. Reason? Overlying skin, whatever is there, It is supplied here by the supraclavicular nerves, which are actually coming from cervical plexus. Root value C2, 3 and 4. So, little different here. You see lateral cutaneous branch of the intercostal nerves will be, even if it is present, it will be very, very small, otherwise it is not present. Even the anterior cutaneous branch never present. In first intercostal nerve is different from them, you can see here. Lateral one, you see this first intercostal nerves, yes. Anterior cutaneous branch not present here, and here lateral cutaneous branch, if it is present, it is very small here. If you look at the second intercostal now, if you look at the second intercostal, again important here, important in such a way that the second intercostal space, okay, it will give you anterior intercostal, because the second intercostal space is lying below the sternal angle. Below the sternal angle, now this time obviously intercostal nerve should supply them, because you know that second intercostal space is between what? It is between second and third rib. Between second and third rib means between second and third means below the second. Below the second means below the sternal angle. Now this skin obviously should be supplied by the intercostal. So the second intercostal has the responsibility to supply the anterior cutaneous nerve, and it should have the lateral also. And incidentally, when the lateral will come, you see that when the second one some lateral will come, incidentally lateral will be, when this lateral cutaneous nerve of your second intercostal nerve comes out, you will see that you have got laterally outside is present the axilla, and in the axilla is lying the brachial plexus, and brachial plexus has got here present lot of nerves, and one of the nerves emerging from brachial plexus will come towards the chest wall, lateral chest wall. Similarly, one nerve, you see the lateral cutaneous nerve of your second intercostal nerves has been given, and here the brachial plexus will reciprocate. It will give here a branch, a twigs, or you see fibers from its one branch, that is called the medial cutaneous nerve of arm, that you will do in brachial plexus. This is called the medial cutaneous nerve of arm, and medial cutaneous nerve of arm will contribute. It will give here a few twigs which will catch hold, you see that it will catch hold, and they will fuse with the lateral cutaneous branch of your second intercostal nerve, lateral cutaneous branch. Otherwise, the second intercostal nerve will continue as anterior cutaneous branch. This is another thing, but the lateral cutaneous branch will now join with the fibers from the medial cutaneous nerve of arm of the brachial plexus to form here a very, very important nerve. This nerve's name is intercostobrachial nerve. Intercosto means partly it is contributed by the intercostal nerve. Brachio means arm. Arm means partly it is contributed by the brachial plexus, the plexus of the arm. A nerve has been actually created. This is called the intercostobrachial nerve. Very important nerve. Many questions come on them. Intercostobrachial nerve. Intercostobrachial nerve, it will be actually a cutaneous nerve that will supply the skin of the base of the axilla also. And because it has got the same root value like your medial cutaneous nerve of arm as well as of the forearm also, that is why problem in them in fact will be, problem in these root rates will be felt on the medial aspect of your arm and the forearm, and even on the medial aspect of your hand also. The pain carrying fibers of the heart, basically they run in the intercostobrachial nerve roots in intercostobrachial nerve on the left side. That is why the pain in the heart or any affection in the heart or ischemic problem in the heart usually is felt not in the heart, but it is actually felt as referred pain on the medial aspect of your arm, forearm and the hand. This is via intercostobrachial nerve. After that we have no problem. 3rd to 6th year just typical, distributed within their intercostal spaces and terminate near the midline as the anterior cutaneous nerve, like you have seen here. You see this is coming here. And during its course you see it is giving lateral cutaneous branch. This is no problem, and this is the posterior ramus here. Posterior ramus never intercostal. Do not call the posterior ramus the intercostal. It is very much daughter of the thoracic nerve obviously, but you do not call them intercostal. Intercostal is after it has been given, after the posterior ramus has been given, whatever now is the thoracic nerve should be called as the intercostal nerve. So anterior ramus is actually the intercostal. You see already the nerves which are actually emerging. This was the posterior ramus, and now it is the lateral cutaneous branch, and now you are watching the anterior cutaneous branch. So whole dermatome has been supplied here, and these nerves already we have told you that how they are actually passing here. They reach up to where? They reach up to the side of the sternum, but you see that after the 7th intercostal nerve onward, 7th, 9th, 7th, 8th and 9th, because the intercostal space does not reach the side of the sternum by that time, because you see that costal cartilages of your next 3 to 4 ribs, they are actually attached here to the to the costal cartilage of the rib above. They do not, because they are the false ribs. So, the intercostal space actually does not reach the side of the sternum. So, here this 7th, 8th and 9th, they actually leave the anterior ends of their intercostal spaces, passing deep to the costal cartilages to enter into the abdomen. By that time they are themselves oblique also. So, when the intercostal space finishes here very early before the sternum comes, because they do not reach up to the side of the sternum, they already finished through their costal cartilages to the cartilage above. So, they are actually so the next 3-4 nerves, they are running in the abdomen here. So much so that when you are actually bringing up your 10th and 11th, for example, one of these ribs is the fallopian ribs, they pass directly into the abdomen here. So much so that when you are actually going to the subcostal nerve, you see subcostal nerve, because it is below the ribs, you will see in the diaphragm has got these two very important ligaments from which it takes origin. This is called the medial arcuate ligament, this is called the lateral arcuate ligament. These we will do actually in diaphragm. So, this nerve is the last nerve, the anterior ramus of your 12th thoracic nerve, this emerges here below the lateral arcuate ligament. This is unique actually in this subcostal nerve, name unique, and their emergence and this passage and journey is also unique. But you see in the typical nerve, I have told you that they have the lateral cutaneous branches, they have got the anterior cutaneous branches, but the very important thing, because lateral cutaneous, anterior cutaneous, they are cutaneous. They are supplying the skin, but who will supply the muscles and others? Actually, it's a very important thing here is that when the nerves enter now into the intercostal spaces in the costal groove, nerve continues, okay, no problem. And it is actually supplying here lateral cutaneous branch, anterior posterior, anterior cutaneous branch, lateral medial. But before entering, along with that, below that will run its collateral branch also. So, in the intercostal, you see in the costal groove, it is not just the nerve itself is running, actually very important will be running along with that will its collateral branch also. You see the collateral for what purpose? Collateral is actually not a cutaneous at all, it is the muscular branch. It is a motor for the muscles which are present there, but it is sensory also, but sensory not for the skin, the sensory for the deeper structures like other somatic structures like endothoracic fascia, like the parietal pleura, like the periosteum. So, it will be for them, this is the collateral branch. So, if for example, this is what we call here the collateral branch. Collateral branch is very important. Usually students just count the intercostal, collateral is running parallel with it. It looks like two intercostals are running, looks like not two intercostal, one is its collateral branch here. And here is this dorsal root ganglion, because when the sensory root is coming and motor roots, they are actually joining themselves at the intervertebral foramen. Here in the intervertebral foramen, the sensory root has its ganglion present there also, because cell bodies of this sensory root is lying in the ganglion, while the motor roots cell bodies are lying within spinal cord. So, here is the ganglion, this green color which you are seeing here, these are called dorsal root ganglion. Dorsal root or sensory root ganglion, other name. Here is the lateral cutaneous branch which have been shown here. At the mid axillary point here, the mid axillary line it is coming. So, here, like here, lateral cutaneous branch. And here is the anterior cutaneous branch. This will be because it will reach here, and it will show here the anterior cutaneous branch. And where they will finish here, see this anterior cutaneous branch, here they will give sternal branches also. These are typical nerves which are typical nerves, because other you see that nerves number 7, 8, 9, they do not reach the sternum. Has been showing you here also, you see this. This is a dorsal root ganglion, the nerve. Dorsal ramus has been given, posterior ramus, anterior ramus name will become now intercostal. You are watching here. Lateral cutaneous branch is given, and here you see anterior cutaneous branch has been given. But at the same time, there will be collateral also, that should supply the muscles here. It has been given from intercostal, but actually not from intercostal, its collateral branch will supply the muscles here. As for the clinical correlates, we have already told you from sternal angle above, you see here, not intercostal, but from the supraclavicular, this is C2, 3 and 4. Below sternal angle, this is now the range, anterior and lateral cutaneous branches, obviously of your nerves. But posterior ramus, posterior wall of the chest here, posterior ramus only. 7 to 11, already the dermatomes have been given here obliquely. You can see here this will be umbilicus is the T10, epigastrium 7, then 8, 9, 10, 11 above the umbilicus 12. This indicates that if the disease is in the thoracic wall, the referred pain will be in If the disease on the back side, you will have the thoracic wall because the nerves are coming in the abdomen, so you will have the pain in the abdomen also, pain in the muscles of the abdomen. So dermatomes because they extend on the anterior abdominal wall. So skin innervation of the chest and referred pain is very, very important clinically. So if you have got the problem pleurisy or any pleural problem in the parietal region, you see of your thoracic wall, your problem will be failed. You see that you have a referred pain here in even in the abdomen also. This is referred pain. This is because of the dermatomes here, because they are oblique dermatomes. You can see here 3, 4, 5, 6, 7, 8, 9. You say this is your 12th thoracic nerve reaching up to the pubic symphysis. You can imagine that. But above the sternal angle, all this will be actually coming from your neck nerves here. Neck means from the cervical plexus. This is now you see is another important condition related to the spinal nerves. This is called the herpes zoster. This is because usually you see in those, in especially those individuals who have the history of the varicella zoster virus, for example, where the chickenpox was there. Usually the chickenpox viruses, they become dormant and they live for a longer period of time, for years inside dorsal root ganglia. Okay, they remain dormant, your immunity and your immune surveillance will not allow them to actually grow there, no problem. But sometimes when the immunity depresses, there is suppression of immunity due to certain other conditions, there will be reactivation of these neurons, these viruses here, and this reactivation will lead here to the inflammation. Inflammation and degeneration of the sensory neurons here located in the dorsal root ganglia of the corresponding spinal nerves. And in the thorax, you see the first symptom will be that there will be band of dermatomal pain. Means if it is, for example, the T10 ganglion involved, so you will feel the pain in the region of the umbilicus, in the dermatomal region of the umbilicus. If it is T3, so you will feel pain here in this region, for example. Initially, it is the dermatomal pain, but later on this distribution of this corresponding nerve, localize it will be on that area only, but it can be even 1 or 2 dermatomes involved simultaneously, followed by after a few days you see there will be blister formation, and this blister will eruption of the blisters will be there, and the rupture, even the inflammation will take place here. You see it will be like here, very painful. You see the blisters here, and these blisters will erupt here and they will rupture also. This is called the herpes zoster, and usually happens when the immunity is low. This happens beyond in the age above 50, but happens in previous history of chickenpox may be there, and viruses are remaining, in fact they persist inside the dorsal root ganglia. This is herpes zoster. Another is, for example, another topic here is called intercostal nerve block. Intercostal nerve block usually indication what? Repair of the laceration, because if you are having a laceration, you want to give some stitches here, you have to desensitize, anesthetize the skin in that area. If rib fracture is there, during respiration you will feel pain. So rib fracture is there, periosteum is broken, periosteum has a breach, so you have a pain, and periosteum is supplied by intercostal nerves to actually minimize your pain. We will try that the pain should not be conducted here towards the spinal cord, so we will desensitize them. So relief of the pain in rib fractures, allowing the pain-free respiratory movements, or lateral, even abdominal wall, repair the abdominal wall or something. If you produce analgesia, want to produce analgesia and the anterior lateral thoracic abdominal walls, you have to do. Intercostal nerves should be blocked, and the intercostal nerves should be blocked means if intercostal nerves are coming, you should actually put the anesthetic solution before your lateral cutaneous nerve actually is coming out. Means behind in the intercostal space, you should put the anesthetic solution, but behind the emergence are the giving of your lateral cutaneous branch, because if you are putting the needle here, your lateral cutaneous branch still will be working, a lot of area still will be having a pain. So you should put the anesthetic solution few centimeters or few inches below behind the mid axillary point, which is the point from where the main nerve you see that is bringing or giving off your lateral cutaneous branch. So if we are actually anesthetizing it at this position, you see lateral cutaneous as well as anterior cutaneous branches both will be desensitized, and whole dermatomal, whole band of skin will be desensitized here, depending upon which dermatome you are working on. This is called intercostal nerve block, and when the intercostal nerve block is there, you put the anesthetic solution in the intercostal space in such a way that if you are putting your needle, this is your imaginary plane, your needle should be actually obliquely inserted here, inserted in such a way that it should not be closer to the inferior border of the rib above, but should be closer here to the blunt superior border of the rib below. Because if you are putting the needle here very close to the inferior border of the rib above, there are chances that the neurovascular bundles should in fact be injured. So, you should put the thing here in this direction. So, they will be cleared off here. This is very important. This is again asked in the examinations. This was something about your intercostal apparatus related to intercostal spaces, intercostal muscles, intercostal nerves. And the next part of your intercostal apparatus will be the intercostal arteries and intercostal veins here. This was your class today.